The following program presents principles designed to promote good health and is not intended to take the place of personalized professional care. The opinions and ideas expressed are those of the speaker. Viewers are encouraged to draw their own conclusions about the information presented.
Hello, my name is Stoy Proctor. I'm here hosting Wonderfully Made. We have wonderful bodies. Today we're going to talk about a part of a woman's body, the uterus, and what can go wrong sometimes with the uterus. The uterus is a cavity that sort of nurtures the fetus while it's growing and eventually propels the fetus, what is known as childbirth. Today, we're very fortunate to have Dr. Alan Handysides, and welcome, Dr. Handysides.
It's good to be with you.
To our program today. Dr. Handysides is a gynecologist and has been so for about 40 years, so he's had much experience in this area. Would you explain a little bit about the uterus and the function of the uterus and the anatomy of the uterus?
Stoy, the uterus, as you have already mentioned, is that container in which a baby grows and develops. It's a very specific and very highly specialized organ. It provides for the nutrition, the correct implanting of the developing fetus. It has a lining which forms the interface between one life and another. In order to perhaps illustrate this for our viewers, because it sometimes is difficult to illustrate for our viewers, what I did was I took a papaya, often known as a pawpaw in certain parts of the world, and I used that, I cut it in half to show the various parts and anatomical parts of the uterus. Of course, a papaya is not a uterus. It is a seed-bearing structure, so it's a plant's uterus, if you want to think of it like that. But in terms of human, it is just an example. But I did do that, and I think our viewers can see the papaya now. Here you see there is this papaya. I'm touching the cervix portion, which would be the neck of the uterus. The top part would be the fundus, and I'm going to cut it and open it up so that we can see what the inside of a uterus might be looking like, or at least have an idea as to the structure of what is going on in the uterus. Now here you see the seeds. These would represent the baby in a normal uterus, but the red flesh would represent the muscle, and the green portion would represent the outside. The inner portion that I am there marking with the knife represents what's called the endometrium, and the lower portion is the cervix. Now I'm taking the knife and cutting off the cervix so that you can see that portion that I have cut off would be called the cervix. And when we talk about cervical cancer, we're talking about cancer in this part. And if we were to talk about the part that's protruding into the vagina, that's the cervix that we can see. The upper part is the body of the uterus, and cancer, if it's going to start in the body of the uterus, would start in the endometrium, the part that I am there touching with the knife blade. Now, as I scrape that off from the meaty portion of the papaya there, but if it were the uterus, that part, that yellowish part that we would be cutting off, would be endometrium. And the endometrium is the part where cancer commonly begins in cancer of the body of the uterus. And so if we talk about endometrial cancer, you'll now have an idea. Sometimes cancer is just in there, but it may extend into the muscle of the uterus, and that is called invasion. If cancer is spreading into the muscle, particularly if it goes right through, we have a fairly extensive invasion of that cancer. Obviously, we would like the cancer not to invade all the way through, but to be restrained to the lining portion of the uterus. So I hope by looking at this pawpaw, we've been able to get an understanding of what we're going to be talking about in the rest of the program.
Now, in your the illustration there, you mentioned endometrial and cervical cancer. Maybe first for our viewers you could explain a little bit about the cancer itself and what really takes place.
Cancer is unrestrained, uncontrolled division of cells. The cellular mechanisms of division are regulated through the nucleus. And in many ways, cancer is a disease that starts in the nucleus. The nucleus of each cell, and every cell, if our viewers will remember, has a nucleus that contains the chromosomes, the genetic material of that individual. If that nucleus becomes damaged, either by infection, possibly by toxin, possibly by hormonal influence or stimulation, possibly by degenerative processes, possibly by inherent weakness, but whatever caused that the nucleus becomes damaged, then the regulation of cell division may go awry. And so cells begin to divide in an uncontrolled fashion. Another factor in cancer that's very important is that the stickiness or adhesiveness with which cells stick to each other is lost in these rapidly dividing cells, which means that they can break off, get into the lymphatics or into the bloodstream, and spread. So there are two ways of spread, either by direct extension, growing into the local tissues, or cells breaking off and being transported in either the lymphatic, which is the drainage of the liquids of the tissue, or in the bloodstream to distant sites where they can set up, and we call that metastatic spread. Those are secondaries that have come from the original cancer. We have in the uterus two predominant forms, although there are several forms of cancer. Two predominant forms. One we call cervical cancer, which seems to have its own particular predisposing factors, and the other endometrial cancer, which also has its own set of factors. And as I explained with the pawpaw, these anatomical sites differ, and so does the progress and the actual characteristics of those cancers.
Now, you mentioned pre-existing conditions or maybe causes, or what are some of the factors that might precipitate endometrial or cervical cancer?
Well, they are different for each of the cancers. Maybe we should start with one cancer and go with that, and then we could explain the other one. Which would you like me to do first?
Endometrial.
Endometrial cancer, all right.
Okay.
If we look at a group of women who have endometrial cancer, we can actually predict that there are certain groups who are more prone to endometrial cancer. So, for instance, if we see a woman who is overweight, we know that she has a risk, an increased risk of endometrial cancer. If she is diabetic, we know she has an increased risk of endometrial cancer. Another factor that may predispose very much has to do with the regularity of ovulation. And if a woman has irregular menstrual cycles, she is not ovulating regularly, she is going to be more prone to have endometrial cancer. So when we look at that, we say, well, those women will probably have fewer babies. So we see people who don't have children, people who are overweight, people who are diabetic, people who have irregular or erratic ovulation or no menses. This group of women are at increased risk for endometrial cancer.
Now, what can a woman do something about? Like she has diabetes. Can she control it? Will that help any?
Well,
what about the regularity of her period? Can she control that? Is there any ways of reducing these risks?
We might need to ask ourselves, what could be the common pathway in all these people that is predisposing to her having endometrial cancer? And the current thinking is that women who are not ovulating regularly, women who are obese, the fat tissue actually produces estrogenic compounds. Women who don't menstruate regularly don't have progesterone. So it looks that the effect of an unopposed presence of estrogen, in other words, not a cyclical estrogen, but a continuous estrogen, may be playing a factor in developing cancer. So what we need to do in that situation in a younger woman is we need to do everything possible to reduce this single hormone stimulation and to get them into the situation that they have a cyclical reaction. So a consultation with one's doctor may be a good idea, because the doctor can then say, look, we can do certain things to induce regularity. Of course, losing weight may be one of those very important things. Good control of the diabetes may be one of those things. So there are things that can be done.
What can a woman do to maybe detect the cancer early?
Endometrial cancer usually comes later in life. And the cardinal feature of endometrial cancer is a change in bleeding patterns. So a woman...
The menstrual cycle?
Menstrual
maybe?
cycle. In other words, it's really not menstrual cycle. It's bleeding that may be mistaken for a menstrual cycle, but is actually bleeding from the cancer that is in the endometrium. Typically, a woman who has reached postmenopausal years, let's say we have a postmenopausal woman, she stopped menstruating, and out of the blue, there appears to be bleeding. That is a very significant finding.
So
She's
it's not getting young again.
She has got to take that seriously, and she has got to go for an immediate consultation with her doctor. A younger woman may find that she starts to have bleeding irregularly between her periods at a time when she wouldn't suspect that she should be bleeding. And so should that happen, that again is indicative that she needs to go and see the doctor.
What's the risk for a younger woman? You mentioned earlier that it was the older woman that usually got the endometrial cancer, and you now say that younger women may also get it. Is it rare, or?
It's much less common in a younger woman. But the younger woman who is obese, who is diabetic, who has irregular menses, has not had children, who begins to find abnormal bleeding, she needs to pay particular attention to this and seek some advice from her medical practitioner.
Is there any test that one can get for endometrial symptoms or cancers?
Well, as with all types of cancers, we do really need to be definitive about the diagnosis. So yes, a history is taken and a physical examination is taken. We might examine the lady and find she has huge fibroids. We may find out that on the history that she's been taking some hormonal preparations or some type of alternative therapies that have hormonal-like activities. So depending on what she's been doing, there may be an answer for the abnormal bleeding. On the other hand, in the absence of clear-cut factors, we may need to say what is going on. The examination may not be very helpful. And in that situation, sometimes an ultrasound examination will show us the thickness of the endometrium, that lining that I showed you in the pawpaw. That can be thickened and enlarged and will be shown on ultrasound to be so. But the most definitive way would be to actually obtain some tissue from the endometrium. And a gynecologist will possibly, even in the office, do what is called an endometrial biopsy. Now, an endometrial biopsy, you take a little cannula, a little plastic cannula. It's inserted...
It's like a tube?
A little tube.
Okay.
It's inserted into the cavity of the uterus. So it would be put where you saw the seeds, although there are not seeds in the uterus. But you put it through the cervix into that cavity, and a little syringe on the end. And with the syringe, you can create a vacuum, a little suction. And then you manipulate that little cannula up and down, and it sucks cells
out of there
into that cannula. Those cells are then placed in a little jar of formalin and sent to the pathologist. Hopefully, the pathologist is going to give us a good diagnosis. Now, in a woman who's postmenopausal, she may be bleeding because her hormones are so low, she has a low-grade infection, something like that, and you do that procedure and you get very, very few cells. The pathologist says atrophic, that means lacking of hormone, atrophic thinned endometrium, no evidence of any malignancy, so that you say, well, this is probably because we're just having a very, very low hormone or inflammation or something like that. But we may also find cells that are indicative of cancerous or precancerous change. And that would be very good. We'd like to see it precancerous rather than cancerous, because that means that the treatment that we're going to do can be done in such a way that we treat this very early. And the prognosis or the outcome for somebody that has an early diagnosed endometrial cancer is really excellent, just very, very good.
But there's really, then, are you saying there's really no test, there's no blood test, there's no hormone test the doctor can do on a regular basis? And that's what I'd like to talk about. How often should a woman go to her gynecologist?
Well, a woman should certainly go to her gynecologist. If we're talking endometrial cancer, and this is not cervical, and maybe I'll answer that question in light of cervical cancer a little differently, but certainly go if she has any bleeding after the menopause. The menopause has come, she's gone a year, she knows she has no further bleeding, and bleeding comes out of the blue, absolutely mandatory that she should go and seek highly skilled professional attention immediately. Don't delay it, don't put it off, take no chances, because you can be 100% cured. Of course, a regular gynecological examination and visit with your gynecologist during reproductive years is advised for most women, because it's much better to pick something up early, and prevention is far better than cure.
Now, suppose, unfortunately, the doctor finds that there is cancerous cells there. What happens then? What about, I understand there's something like putting this cancer in stages of seriousness?
Well, of course,
like staging?
As with all cancers, we want to stage. You know, there are different systems of staging. One is the tumor itself. One are to see if there are lymph nodes, and the other is metastasis. So we sometimes call it the TMX or TNX staging system. What really needs to be done is to see if there's any evidence that this cancer has spread. So the doctor will order a series of investigations, the aim of which is to show the extent of the cancer. If the cancer is spread to the pelvis, to lymph nodes, and so forth. And so to do that, he may order bone surveys, he may order MRIs, ultrasound, but MRI is probably what he's going to want to do to see that. He may do x-rays of the kidneys to see that the kidneys are draining well, and so forth. But once he has delineated this, then there are two principal modalities. The one for endometrial cancer would be a hysterectomy, which would include the tubes and the ovaries, because one would want to get a wide scope here. If lymph nodes are detected by extension, then further therapy would be added. Radiation therapy is usually done in conjunction with the surgery. So because the surgeon says, I think we will use radiation, doesn't mean that he believes that you have a particularly worse situation, but we know that the results of radiation combined with surgery give better results. Some give the radiation before, some give the radiation afterwards. Your own practitioner or your own specialist will tell you, the gynecological oncologist will tell you what is the preferred method of treating your particular cancer.
Now, this is serious, taking out your ovaries and all those sexual aspects of a woman. Should someone ever think about getting a second opinion?
I think it's very wise to have second opinions. Second opinions are good for the physician. Second opinions are good for the patient. You don't look back and think, I wish I'd done this or I wish I'd done something else. In a clear-cut case, most cases will follow what I have said. And it is serious to have the uterus removed and the ovaries, but fortunately it's an older woman's condition, and by that time many women have ceased to need their uterus for childbearing procedures, and they are postmenopausal, and so the hormone production from the ovaries has dropped. So usually women do not notice it as being very serious as far as hormonal deprivation is concerned.
Now, if a woman has a hysterectomy, how is that going to affect her sexually, the way she feels, her energy level? Well, how does that affect? Any notice any difference?
I think that some women claim that it does make a difference, and we would be insensitive to their claims if we said it didn't make any difference. In reality, in large studies, people who have sexual difficulties after a hysterectomy are not very much increased over those who do not have. Sexual difficulties may come for reasons of hormonal depletion, aging process, and so forth. We sometimes say that a woman who has a normal sexual drive, normal sexual activity before, will continue to do so afterwards. And a person who has had problems or difficulties will continue with problems and difficulties afterwards. But of course there may be some consequences of surgery that could cause for pain, scarring, and tissue damage. And a woman needs to be appraised of all of these by her physician.
Now, another type you mentioned earlier was cervical cancer. How does that differ from endometrial? Of course, the place is different.
The place is different,
as you've explained. But,
and it's a different cellular process.
Okay, tell us about that.
With cervical cancer, we're looking at a situation that the epidemiology of it, that is studying the population that gets it, they found that people who had early sexual encounters, multiple sexual partners, and women who had been or had evidence of having been infected with the human papillomavirus, those people have a much greater risk of cervical cancer. And today we believe that the bulk of cervical cancer, not all, and I would not want our viewers to go away with the idea that anybody who had cervical cancer must have had a human papillomavirus infection, but the bulk of them are probably related to that. There are other forms of cervical cancer that are not related to human papillomavirus. It also seems that herpetic infection, herpes, plus human papillomavirus may increase the risk.
How are these acquired?
Well, these are all sexually transmitted and acquired through sexual intercourse. That's why multiple partners and beginning very early seem to be factors in predicting whether you will get a cervical cancer.
So that's one of the difference between cervical cancer and endometrial cancer.
Endometrial cancer, very big difference.
In other words, early sexual encounters have nothing to do with that.
Endometrial cancer. Now, another interesting feature here is smoking. They have found that women who smoke have an increased cervical cancer, and women who take birth control pills seem to do. But it is thought that it may not actually be a direct effect, but just an associated effect, because women who start on birth control pills early may have more sexual partners and be more sexually active than are people who don't. And smokers, we know, women who smoke also are more sexually active and may have more sexual partners as a group, not as an individual, of course, but as a group. So that shows through when you start looking at the epidemiology of cervical cancer.
So some of the things that we can do or maybe instruct our daughters to do or not to do would be not to smoke. First of all, not to have early sexual partners.
I think that's the order, yes.
Multiple. Which order would you put them in?
Well, first of all, I think that it's definitely related to the sexual activity.
Okay.
You see, and of course, when they are rebellious or when they are wanting to prove their womanhood, sometimes they smoke. And those same motivating factors that would lead them to smoke sometimes lead them to be experimenting with sexual activity and to be more interested in sexual activity than would be people who tend to take a more measured lifestyle and be more controlled of themselves. But I think we need to teach our daughters that there are dangers in early sexual encounters. Particularly young girls seem to be more at risk for human papillomavirus infections. So it's very, very important for us to stress that.
And this is probably related to taking drugs or taking alcohol.
And of course, alcohol, the whole scene, you see.
Yeah, it's all
these
sort of
pictures all tie together. So using alcohol, using drugs. Drugs are often used to heighten sexual activity. So all of these factors tie together. So the lifestyle that we choose when we are very young may actually impact us even later. I remember seeing a 70-year-old lady who had cervical cancer. And it came on, at 72 I diagnosed it. And when I took her story, she told me, yes, when I was young, I used to be sexually somewhat promiscuous. And so she had carried the virus for many years. The virus had got into the nucleus of the cells and over the years had caused trouble. Now, we would be remiss if we didn't stress the importance of the Pap smear.
Oh, yeah. So that is a test we can do for that.
Because
we don't have that test for endometrial, but we do
right.
for cervical.
But for Pap smears have reduced the numbers of deaths. I remember sitting in a clinic in Africa. I worked at the King Edward VIII Hospital in Durban for a year. We could walk in there. There may be 200 people in the outpatients, gynecological outpatient, coming to see us. You could walk past and smell the 2 or 3 women that day that would be coming in with cancer of the cervix. Of course, at that point, it's too far gone because it's invaded the bladder, it's invaded the rectum, maybe it's closing off the tubes coming from the kidney. Those women are doomed. But if it can be caught early, it can be treated so successfully. So the Pap smear has reduced the amount of deaths from cervical cancer so dramatically. And it's a simple test. So we recommend for most women over 21 that they should go. Now, a virgin who has not had any sexual activity probably doesn't need to be having a pap smear, but a woman who has been even maybe not, is still a virgin, but has been sexually experimental, may acquire human papillomavirus. So we do recommend that people should be checked, and they should take a very great care to look after themselves, even if they have had sexual dalliances along the way.
One question. What about personal hygiene, daily bathing and things like that? Does this have anything to do with it?
Well, you know, one's personal hygiene is a reflection of one's lifestyle, and people who are clean will be punctilious about their care. But you can be as clean as you like. The human papillomavirus will be transmitted even in clean people, so you have to be careful about your partner. That's why it's important for partners not to have many sexual dalliances, because they may finally settle down, but they bring to their marriage these viruses that can cause disease.
Now, you in the illustration of the papaya, you cut off the end. That would be surgery. Would
no,
it not?
But that was just to illustrate
I know,
what the cervix
but
was.
what about surgery?
Well, we have to quickly go through the treatment maybe of cervical cancer.
Quickly.
In the very early stages, we can actually skin the surface and get rid of the cancer. That can be done with cryo-freezing therapy, can be done with electrotherapy. It can even sometimes just be cut off with a conization. But if the cancer starts to extend, then we are either going to go to radiation, and radiation therapy is very, very useful for the cervix, because you can put a rod containing radioactive material right into the cervix and actually radiate it. The problem with cervical cancer is when it's diagnosed late and has already spread to the other organs. In that situation, we're going to have much more difficulty in controlling it. Although great things can be done, and major surgeries can be done to clear it out, but it's much better to diagnose it early. So the takeaway message that I would like to leave is, please, if you're a woman, take good care of this wonderful body that has been given you. And if you feel that there may be a problem, follow up early. Don't delay.
Very good. I want to thank you, Dr. Handyside, for being with us today, enlightening us on this important topic. And to our viewers, I want to thank you for watching Wonderfully Made today. We have discussed an important topic about an important body of ours, the only one we'll ever have. And so, remember, if you have any irregular bleeding, go see your doctor. Go to your doctor to get a pap smear on a regular basis. Keep faithful to your husbands. And if you're not yet married, wait until you do get married before you have sexual activity, because that's going to protect you from having a very terrible disease. And remember, it's curable in most cases.